Thank you, Dr. Madhu, and thank you all, because on the last day, before going home, so many people are here. We are very happy to see you all. And we are going to the last presentation of the day. It's on intraocular foreign body, mostly something very practical. We will not be talking much of the theory here. And unfortunately, nobody is interested in me financially, so I have got nothing to declare. This window, post-trauma window, is very, very important, especially in case of open globe injury. So we classify them into acute or subacute or chronic. Why this window? We'll just see. See, the management strategy varies. In case of an acute window, it is basically to restore the integrity of the eyeball and to avoid the infection. If the patient is coming in the second window, basically what we want to see is they will usually present with the sequelae. And most of the time, we are talking about the foreign body and the open globe injuries. Here, it most of the time requires the expertise of the VR surgeon, right? So coming to intraocular foreign bodies, almost 18% of all foreign bodies are posterior segment trauma. It constitutes 18% of the posterior segment trauma and 40% of the open globe injury. And most of the people are in the productive age group. And this is one of the male-dominated area where only majority are males who are affected by intraocular foreign body. And it's almost 60 to 80% are because of hammering. And it is not the the rock piece which enters the eye. It is basically the pieces from the chisel which enters the eye. The risk include infection or RD or metallosis. We have come across a lot of these cases with the metallosis. And again, when you classify the foreign body, it can be reactive or inert, right? Usually inert foreign body need not be removed. So gold is one such thing. But the problem with the gold is we don't know the purity of gold in India. Even though it's a 916, we don't know what amount of copper is there in that. So even if it is a golden eye, it is better to remove. The reactive foreign bodies are charcosis, which will almost present like an endophthalmitis, and iron will present with a cirrhosis. If it's a metallic and if it's magnetic like iron or nickel or steel, which almost constitutes 55 to 80%, it is very easy to remove because magnets are very useful. If it's non-magnetic, then we'll have to use the forceps. And non-metallic includes stone, thorn, and glass, and sorry for the spelling mistake. The sides are 15% are in anti-segment, 70% are in the posterior segment, and 8% are in the orbit, and almost 7% are in the, 7 are in the orbit. And it depends on the velocity with which it travels, the nature of the foreign body, the size of the foreign body. So the most important thing is localization. History is very important. We'll go one by one. And the most important thing is direct localization. If the patient comes with a foreign body history, immediately you dilate and look for the foreign body with indirect ophthalmoscopy. That is the most precise way of localizing a foreign body. The other things include X-ray. X-ray has to be done mandatorily because for all practical purpose, X-ray is the medical legal document. Without X-ray, if the patient goes to the court, then we are sued. And 40 to 60% can be detected with just X-ray. Depending upon the silica content, you can visualize the glass foreign body. But the problem is precise localization is not possible. Precise localization in cases, in places where you don't have a CT or MRI or other ultrasound, still it is possible. You go for this is a foreign body, but we don't know where it is located. Just go for a limbal ring. There is a separate calculation. I will not go into the details. You create an artificial eye. Then you know in laterally how far it is from the limbus, and in the anterior posterior direction you know how far. And this is one of the cases who had an injury with this ball. He was hitting the cycle, this thing, a free wheel. The baldness has entered his eye, and you can find it in X-ray. Then we went for the limbal ring. In the limbal ring, it was quite outside. When we created, we don't need to create an artificial eye because it was quite posterior. Then we went in for the next investigation CT. Through the eye, it was located in the frontal lobe of the brain. Of course, we don't need to do anything. We cannot do anything. We just left it. And the patient was PL negative in these cases. This is another interesting case. The patient came to me saying that he was drugged and kidnapped by some people, and they have put some needles in his eye. You can see many hypodermic needles in the eye. So he came with an X-ray which was taken elsewhere, but we thought something fishy. So we thought we'll take one more X-ray. If the X-rays, the needles are more than that, there should be something fishy. This is the X-ray taken somewhere else. And few months later, he came to me. And this was the X-ray taken by us. You can see more number of needle in the eye. Then on inquiry, this was a self-inflicted injury. Of course, he was not suffering from any lesion in hand. It was self-inflicted. The reason he said is he was not getting married. That's why he was taking the hypodermic needle of his diabetic father and putting in his eye. I said, if you got married, you have put it in both eyes. I'm sorry. Okay. Then we went in for a CT scan. And then this picture actually, it was the 3D construction of this. We could found this in his eye. More than 60, 70 needles were in his eye. So this was the 3D construction of the patient. We removed whatever is possible, and then he was given a psychiatric counseling, and we have been following up this patient actually. This is one such case. So in all these cases, history is quite important. And I think I'll skip this video. We just removed the needles which were protruding. Ultrasound is very useful because it is the important usefulness of ultrasound is the collateral damage can be found. You can see whether there is a scleral tear or vitreous hemorrhage or retinal detachment. But only thing is sometimes it's quite poor in specificity. And if you are very forceful, you can expel the foreign body also by pressing the foreign body out of the eye. And in ultrasound, if you precisely localize the foreign body, that means you have mastered. In this case, because of the velocity, you can find that the foreign body is in the middle rectus muscle of this patient. And wooden foreign bodies are better localized with CTR MRI. And don't do MRI if you suspect a metallic foreign body because it can move 7 to 8 millimeters in suprachoroidal space or 10 millimeters inside the vitreous cavity. So you'll have a lot of damage when they do the MRI. And of course, you cannot visualize the bony shadows. The management objectives in any trauma, it is basically to preserve the integrity, prevent the infection, remove the foreign body, maintain the clear media, manage the RD and IOP control, and prevent sympathetic ophthalmia in the fellow eye. Okay, all reactive foreign body should be removed. There is no question of leaving them. Inert foreign body, in case if they cause mechanical damage, has to be removed. And it all depends on the nature and location of the foreign body and the type of the injury also. So anterior, posterior, and pars plana root are done. The first two are quite ancient. We no more advocate unless otherwise it is protruding through the sclera. Usually it is with the vitrectomy in the pars plana root, we do it. And all the phacosurgeons, we are also moving into this so-called small gauge surgeries. We usually go for hybrid. Initially, you do everything with the 23 gauge vitrectomy and extend only one port if the foreign body is less than 4 millimeter. And we have got a wonderful magnet. So do the vitrectomy. You can see the foreign body moving inside. It's not quite correct actually. Now this is an intraocular magnet, almost 18 gauge. Just extend. The only trick here is you align the foreign body to the long axis of your magnet, right? Once the foreign body is picked, just align, because if it is in horizontal axis, while coming out through the sclerotomy, it can get stuck. So once it is aligned, just it's a very simple thing. To interrupt suture, and the rest of the thing cannot be sutured. And we can remove the foreign body very easily. Suture it looks very clean. And this is a stone foreign body. In case of stone foreign body, the problem is we cannot remove it with a magnet, right? So in such cases, do a complete vitrectomy, and it is we inject PFCL just to prevent any damage. You can make out quite a large stone, and it is usually picked with a forceps, and it is usually removed. In this case, we make a tunnel, scleral tunnel, and just remove it through the tunnel. I think we have completely wiped off the endothelium during this procedure. Maybe we'll have to go for corneal procedures later. And we get a lot of variety of foreign body. This is a case of a subfoveal foreign body, and I think the video is skipped. And this is another interesting case. The child was playing, rotating this chain, I think one end of this chain, the lock has gone into the eye of her father. So it was quite large and it was an unusual foreign body, causing damage and a lot of vitreous hemorrhage also in this case. And it's non-magnetic, it's metallic non-magnet, quite large actually. It was picked with the forceps and removed through the pass panel. And fortunately, this patient was maintaining 624 vision for some time and then it became 660. But whether the patient is happy or not, by giving back this lock, I think we have restored the chain, if not the vision of the patient. And prophylactic buckle, whether we should do it, I don't think most of us do it now, but it is totally depending on the clinical scenario and the risk of the RD. But prophylactic antibiotics are a must in any closed globe, open globe injury, because 15% of the cases they go for endophthalmitis. We don't give steroids, only Vanco and Septa are given intravitreally. And in the absence of any signs of infection, whether you should give antibiotics is controversial, but strictly speaking, Vanco and Septa are quite safe. There is no macular ischemia or any such reaction, so injecting them is not a bad idea. And anybody can inject, actually, it doesn't require any post-segment surgeon to do that. And prognosis depends on so many factors. It varies with the size and composition, whether it is inert or whether it can cause metallosis. And in the first case, even if the foreign body is left in situ, if it is inert, nothing much happens. Usually the prognosis is good, especially in case of glass foreign body, because most of the time in removing the glass foreign body, we cause more damage while doing the surgery rather than during the injury itself. In case of metallic non-inert foreign body, chemical foreign bodies, it is better to remove. Otherwise, the prognosis is usually bad. They come with cirrhosis bulbi. These are few cases where we had a nice time in removing the foreign body. It's quite a large one. This is almost a 14 millimeter. And this we have discussed actually. So another thing which makes the prognosis bad is the previous operations. In all cases, prognosis should be guarded. And we can use the trauma scale also, give them the prognosis. Lens damage also worsens because it causes poor visibility and also it leads to lens-induced complications, and rehabilitation is also quite late in these cases. And thank you for your kind attention. Any questions, we can take it.